Good morning, everyone. Hope you can hear me and see me okay. Thanks for joining us today for our Forward Texas digital series. My name is Terrence Henry. I'm the Executive Director of TAMEST. That's the Academy of Medicine, Engineering, and Science of Texas. We are a nonprofit that is a statewide organization that supports collaboration to advance research, innovation, human talent development, and business in the state of Texas. We're composed of more than 300 Texas-based members of the 3 National Academies of Medicine, Sciences, and Engineering, as well as our state's 11 Nobel laureates. We're supported by the founders of our endowment, as well as our 18 academic member institutions, and we want to recognize them for their ongoing contributions to our research community, as well as the health and vitality of our state. So thank you for your support. We're also supported by Hill Philanthropies. They're sponsoring this session in this series. Hill Philanthropies is committed to funding transformational advances in science and nature, empowering nonprofit organizations, and improving the Texas and Colorado communities. So we're really excited everyone could be here today for this session. We think this is a very timely topic, given the trajectory of the pandemic and the impact it's having, particularly on our rural and underserved communities in Texas. Today's session is going to focus on rural healthcare and telemedicine. And it's going to be a 1-hour session. We're going to have some audience Q&A towards the end of the session. We have 3 speakers joining us today, as well as our moderator. When we do get to the Q&A portion, or really at any time during the session, if you have a question for the panel, please use the Q&A box on Zoom to type in your question, and we'll address it during this session. So without any further ado, I'd like to introduce our moderator for today's session. Dr. Nancy Dickey is Executive Director of the Texas A&M Rural and Community Health Institute. Dr. Dickey is a member of TAMEST from the National Academy of Medicine, and she also chairs our annual conference planning committee. Fingers crossed, we will be having that conference in January 2022 in San Antonio. And with that, Dr. Dickey, we'll turn it over to you to lead today's session. Thank you.
Thank you, Terrence, very much for that introduction. We are delighted to be here to be a part of the series. As a result of the COVID pandemic, the webinar series is actually a new innovation, and we hope that it is one that will continue long past the pandemic. In fact, part of what we want to talk about today with telemedicine is that while we sometimes emphasize all the bad legacies of the pandemic, there hopefully will be some good things, some lessons learned that'll move us forward. I'm honored to be joined today by 3 experts in telemedicine, each from a somewhat different perspective. And we're going to talk about telemedicine and particularly its impact on rural health, the ways it's used, the ways it could be used, some of the barriers and some of the problems that we have. We're going to take a little different format perhaps than usual, in that each of our presenters is going to share some brief remarks from their perspective, and then we're going to have a conversation among ourselves. But I would invite all of you to feel free to use the chat format there and send in your questions. We'll try to incorporate those right into the conversation we're having, and we'll try to be sure that we keep answering those questions as we go through the conversation. So let me introduce the speakers you're going to be hearing from today, and then I will ask them to each just step in that order and talk about telemedicine from their perspective. So first, we're being joined by a Texan. Nora Belcher is the Executive Director at the Texas eHealth Alliance. It's a nonprofit advocacy group that serves as the state's leading advocate for the use of information technology to improve healthcare systems. Nora is well known to many people in healthcare, and certainly to policymakers and legislators. She's a computer programmer by training, has a degree in public policy, and is a voice in front of our legislature year after year. Following Nora Belcher, we'll hear from Dr. Alex Vo. Dr. Vo is the Vice President for he's the Vice President and Chief Commercialization and Strategic Ventures Officer. That's a real title, Alex, at the University of Texas Medical Branch. He works with the Virtual Health Network at UTMB, which is a statewide telemedicine network connecting the pieces of the University of Texas healthcare institutions. Does lots of telemedicine policy work, but as you can see, also gets involved hands-on in some of these programs. He's an innovator by history and has helped create 6 companies to commercialize clinical and research enterprises. He's used to being out there on the cutting edge. And then we're going to go out of state and we're going to hear from Dr. Kelly Roan. Dr. Roan is the medical director of outreach and innovation at Avera eCare. She is an emergency physician by training and continues to work actively in both real emergency rooms and telehealth emergency rooms, keeping her skill sets up to date. Her passion for rural health makes her an expert in looking at ways to solve problems for access in rural areas. We're glad she's there at Innovation and Outreach. So let's hear from these 3 experts that will set the conversation for the rest of the hour. Nora, you want to start?
Of course, Dr. Dickey, thank you so much for the introduction and for having me today. This is a really great audience for me. I'm used to being in front of the legislature, and they're not nearly as nice as this crew appears to be. So I'm really happy to be amongst friends today. I think I want to spend my 5 minutes talking about a couple of really big Darwinian evolutionary leaps that have just happened in the telemedicine policy space because of the pandemic. And I have to concur with what Dr. Dickey said. You know, I didn't ask for the zombie apocalypse, but I'm glad that my community was prepared and stepping up and kind of kicking ass and taking names during said zombie apocalypse. So in terms of telemedicine policy, there are 3 major things that have happened that's important for stakeholders to know. The first one is that telemedicine has always had what I call a chicken and the egg problem. Well, show me the data that this works in Medicaid. Well, give me permission to do it in Medicaid. Well, I'm not going to give you permission to do it without the data. Well, I can't give you data on Texas Medicaid unless you let me do the telemedicine. And so we end up chasing our own tail frequently in telemedicine policy, where state policymakers might say, experience from the VA doesn't really map to our Medicaid population. We want data that's really specific, when what we're asking is for permission to use that population to do telemedicine with. So the pandemic has sort of wiped the chicken and the egg problem away. Back in March and April, in order to keep people safe, preserve personal protective equipment, governors in all the states really opened up telemedicine and telehealth services in the commercial markets, in the Medicaid programs. Medicare, which had traditionally been the worst, and I say that with affection, payer, in terms of telemedicine, added hundreds of codes and hundreds of services and really expanded. And it's been really, really good for patients and for the system. It's also let us build provider capacity, because outside of some areas where we really have sophisticated work being done, behavioral health is an example, some of the work that Dr. Roan and her team does, and I will not steal any of that thunder because it's amazing, that was already in place. Everybody had to sort of learn to adapt to this new reality. So that's piece of good news number 1, is we now have data and experience to really inform decision-making in spaces that we didn't have telemedicine and telehealth before. Piece of good news number 2 is the pivot of our patients and our providers. So prior to the pandemic, less than 20% of patients and providers really had experience with these technologies. On the provider side, depending on who you ask, it's now between 80 to 100%. Patients, we know from one survey, at least 4.5 million Texans have gotten a telehealth service during the pandemic. Medicare is showing these huge numbers, particularly in primary care. And the analogy, I love analogies. They're very helpful. Y'all may all remember when America Online sent everybody a CD-ROM in the mail, and we woke up one morning and everyone had an email address, and My grandmother didn't. She thought it was a coaster. She never quite figured out what to do with the CD-ROM. But we woke up and everybody was online and everyone was on the internet and everybody had an email address. And we're going to look back on the pandemic as the time that digital health sort of broke through to the consumers as an option that most people didn't even know existed prior to 2020. It's going to be really hard for a lot of consumers to say to them, you've got to go back to sitting 3 hours in a waiting room or driving for 3 hours or missing 3 hours of work, particularly for basic primary care. That's one of the big lessons that's come out of the pandemic. So the last thing I'll say as a frame is the legislators are fighting all over each other to be the champion for telemedicine and telehealth in the 2021 session of the Texas legislature. We already have bills filed around payment parity for private insurance. We're expecting to see legislation to make the Medicaid flexibilities permanent. We're going to have lots of good data, I think, to back that up. And you're also going to start to see spillover into other areas. The most fascinating example that I can think of is teledentistry. So as opposed to the expansions that were done in medicine, dentistry really contracted during the pandemic and people went without services. And I think there's going to be a terrible price to be paid figuratively and literally for that. Not to mention dental practices going without revenue. So they'd been real resistant to the tele, and now all of a sudden, all those stakeholders are showing up saying, hey, hang on a second, we've got to revise our regulatory structure. So I'm going to stop there, but that's sort of a 10,000 foot view of the policy landscape. It's completely different from 12 months ago. So I'm going to be very busy and I feel unnervingly popular, but I've got great partners at A&M, at the University of Texas, with the vendor community and others to help me work on this during the upcoming session. So with that, I will turn the microphone, Dr. Dickey, back over to you.
I know better than that. Thank you, Nora, for those comments. And with that, let's slide over to Dr. Vo and talk to us a little bit about your innovations and how it's being used.
Thank you very much, Dr. Dickey, and really appreciate the kind introduction earlier. And it is a real title. It's really long, so I just call myself Innovation Officer at UTMB. Anyway, just give a brief history of UTMB and how the pandemic has affected us in terms of how we have utilized telemedicine. You know, we've been doing telemedicine since 1994, so that's 26 years. Very experienced in this space, starting out in the correctional environment. We manage most of the prison system in the state of Texas and provide about 150,000 encounters a year pre-pandemic to those facilities. And over the years, over the 26 years, we've expanded to more rural areas, school clinics, underserved populations. We provide all the medical services, including telemedicine, down to Antarctica, to the scientists and the workers who live down there currently, the cruise industry, and of course, corporate health. And so every year we average around 175,000 non-correctional telemedicine encounters, which places us as a pretty large academic, provider of services. COVID actually changed a lot of things. It actually forced us to innovate in ways that we have not done so in about 3 decades. And out from COVID, we actually started doing 5 different models of innovations that we were not used to. And that took place fairly quickly, mainly over a period of a weekend, like from a Friday to a Monday. We went from, 30, 40 consults a day in primary care to 2,000 averaging daily, which is really crazy, to be honest with you. But what we did was, we innovated around 5 different models, like I said. One was a telephonic triage line. We really utilized the telephone significantly to essentially assess for symptoms and direct care for patients to our specific clinic locations that has been designated as capable of diagnosing and treating patients who have been exposed to the coronavirus. As you know, you have to actually have special protocols and protective protocols in place in order to handle these patients. So we use the telephonic system quite a bit to actually triage for that. Then we actually started using our EMR and other third-party platforms to do virtual care for at-risk populations, mainly folks who are geriatric based OB clinics and pediatric clinics. So we provided telemedicine through our homes to do follow-up and making sure that these folks get the continual care that they need. And then that follow on to that is obviously wellness and medication refill, because that was a big part of it. Remember, a lot of places shut down for months on end, and medication refill is very an important component of providing care and continuity of care. And then we started doing this thing called peer-to-peer consult, and that is essentially using telemedicine within our hospital clinics and locations where patients have been hospitalized, and our providers, like our infectious disease providers, were providing expertise consult to our ICU providers on how to take care of some of these patients, and mainly to conserve PPE use, as well as distributing the specialty knowledge that is there. And we started doing that in ER as well, so providing specialty care into the ER, our own ER. And you can imagine for rural health, that model could be really important to sustaining some of the community hospitals out there, providing that specialty care capability. And then we started, the last thing was developing this virtual primary care clinic piece. So we developed a virtual primary care clinic staffed by a pool of virtual providers who can take calls from patients and their families at any time. And so that actually expanded our reach and our ability to actually be available to our patients during lockdown periods, et cetera. And minimize exposure to the virus early on. So over the years, we've innovated quite a bit in terms of various technologies, obviously, and doing telemedicine. But this past year has really seen the most growth in terms of innovation, not only in technology, but the way you deliver care that we have seen in a long, long time. So I'll stop there for now.
Well, he deserves the title of Chief Innovation Officer, obviously, and when you increase your numbers by those kinds of factors, it's pretty impressive. I have some questions I'll come back to, Dr. Vo. But let's go to Dr. Kelly Roan. Kelly's in South Dakota and is actually using telemedicine on a day-to-day basis, but is also the Chief Innovation Officer for her company. Dr. Roan, tell us about telemedicine from your perspective and rural healthcare.
All right, well, thank you for having me here. It's fun to talk to everybody today. Terrence, will you go ahead and just go to the next slide? Just a little bit to kind of show you how we got started in this. Avera Health is the health system that I work in, and we have 37 hospitals, but what you should know is we cover a 5-state area. We are headquartered in Sioux Falls, South Dakota, straight north of you guys. But 80% of those hospitals are critical access hospitals. And so we started using telemedicine quite a long time ago, just to be able to access our patients. In the next slide. And so we were actually tasked to grow this outside of our system and to use what we've learned in our own health system to help others. And so throughout all of our service lines now, we have 600 sites in 32 states. But we do serve about 17% of all the critical access hospitals in the nation. So rural has always been very important to us. Next slide. And when you look at our virtual hospital, we're actually not connected to our physical hospital, but each section or service line is kind of separated by a small wall so that we can actually pull from each other's knowledge. So we've seen millions of patients through this virtual hospital, but none of them have ever come through our doors. And each one of these areas just uses a little bit different technology in order to see our patients the way we need to. Next slide. And so similar to Dr. Vo, we started in the early 1990s, and as connectivity got better, we were really able to increase our services to different populations and kind of dream and innovate in new and different ways. Next slide. And so telemedicine can look different depending on how you're using it. And so you can see here that we may have different modalities between carts and lots of different software to very easy connections. And we'll probably talk a little bit about connectivity later. Next slide. But just to see how this looks in an emergency department, We actually have a direct connection to our emergency departments because we don't want to lose connectivity by using things like Wi-Fi. And I think as connectivity improves, we'll be able to do some of those things. But I'm actually able to connect right after the emergency department hits a button on the wall. You can see that little red box on the left-hand side screen. And they hit that button just like they would a code button in a hospital. And that brings us up on the camera. And then on my side, I'm able to move the camera so that the staff never has to leave the patient's bedside. I can talk them through procedures, such as I've talked to lots of people through their very first time chest tube, or we do about 3 cardiac arrests every day. So we're very much seeing very critical patients, but also seeing kind of that bread and butter patient and, hey, can I just run this by you, or can I get a second opinion type thing. So really easy for me to do things like look at an EKG or discuss a case with a provider or a patient. And we also use nurses to support the nursing and to document as well. And then next slide. And one of the things that we have been able to do is to actually help with intubations. And I have to say, this is the single most scary thing that we do over the camera. And so we were actually able to look at the video laryngoscopes, and most of them will allow us to connect right to our cameras. And so I'm able, as they are looking in that airway, I'm able to see that airway in 42-inch screen. So on the right, you can see a nice picture of an airway, that upside down V, that is your vocal cords. You don't always get this pretty picture like you do here. And so as I'm watching what they're doing, and some of the people who are working in the emergency department are, maybe just don't have a lot of airway experience. So we do a lot of teaching. But I can also say, it looks like you're not deep enough. I need you to, just go a little bit deeper. Okay. And I can talk about the landmarks, but then tell them you need to lift up or maybe rotate to the right, or I can see kind of where the tube is hitting and give them some hints of how to increase their first pass technique and save the patient. So go ahead and go to the next slide. And I'm just kind of putting some of these up because I want you to think of telemedicine in a little bit different way. We often think of telemedicine as a patient just having an appointment with a specialist or a physician, but really we are seeing the sickest of the sick, and we're also taking care of patients at home. So this is our EICU, and you can see they use multiple screens and they're looking at multiple data points. And so they actually have specialized software that help them to find any trouble spots and bring that up so that they are able to help the bedside team to notice any negative trends and able to put in orders for that. And next slide. And then during COVID, which I'm sure we'll talk about, we did a ton of education. You can see these pictures are from pretty early on in the pandemic because we're all sitting pretty closely and we don't have masks on, which seems pretty foreign right now. But when we did all of this is our incident command, which we actually put at our telemedicine education center right here in our building. And with each plan of our incident command and our disaster response, we actually layered telemedicine. So everything from call center and drive-through testing to seeing people at home that are high risk and taking care of them at home, all the way to inpatient and ICU. And this has really helped us to keep many patients out of our tertiary hospitals and to keep them in many of our other hospitals in our health system. And in fact, about half of our patients that are hospitalized never came to our tertiary care center, but we were able to help care for them with the help of telemedicine. And I think having that set up prior to the pandemic just helped us to be able to adopt that really quickly. And then next slide. And this is just a picture of some of my partners, some of the physicians, and love to turn this back over to you, Dr. Dickey, for some conversation.
Well, I thank all of you, and you've gotten some very different perspectives, although one of the things that threads through all of this is that telemedicine is not really new. It's been around for a couple of decades, often in relatively sequestered spots. And what the pandemic has done is kind of force some rapid change. One of the places that we aren't feeling a rapid change, and Dr. Roan, you addressed this in passing, is some of the places that would most benefit from telemedicine, whether it's provider to patient or peer-to-peer, doctor to doctor, doctor to nurse, lack reliable connectivity. So even as we're talking about these tremendous opportunities, what are the steps that we take to try to get our connectivity at the same level as the regulatory access changes that occurred during COVID? Thoughts about, is that a state by state? Is that a national issue? Nora, maybe you're one we should turn to for some answers there.
You know, one of the only things more popular at the Texas Capitol right now than telemedicine is broadband. There are genuine kind of wrestling matches going on over who's going to be the champion for rural broadband, not just for healthcare, but for overall economic development. One bit of good news I do have to share is that I do think Texas will finally develop a state broadband plan. And that's important because we don't have coordination of our broadband resources in any organized fashion right now. There's still a lot of federal money that's untapped. I think one of the conundrums that has to be solved is that a lot of the federal funds for broadband, a regular physician practice won't qualify for, because those broadband funds are for nonprofits, or they're for academics, they're for different sorts of organizations. And Dr. Dickey, you know this from your rural health work, a lot of our rural health physician practices, the 1, 2, 3 doctor practices, they're businesses. They're not any kind of a nonprofit that qualifies for any of that federal funding. So the good news is I think we're going to see finally some concentrated, focused policy effort. The bad news is I don't know that there's an easy solution for the regular physician community as opposed to a community public hospital or a federally qualified health center that can still qualify and should go try to get federal funds, because there's still a lot of federal money available. But yeah,
I want to add, if I may, to the reason why there's so much federal funds still available and not a lot of folks tap into it are precisely what Nora just mentioned, the eligibility piece. But also one of the things that prevents us, even as an academic nonprofit academic medical center, from going after it is that they require you to have certain type of partnerships, which is fine. But in addition to that, some kind of matching funds you need to pony up, as well as in-kind contributions. And a lot of organizations just can't do that. So I would applaud any kind of state initiative to actually do the capital investments into doing, providing connectivity across the state. Because right now with the federal, even though there's federal opportunities, those opportunities are difficult to obtain just by nature of their requirements.
So Kelly, you're in 32 states. Is this a Texas problem, or is this a national problem?
No, it's absolutely a national problem. I mean, we've had, when we went into Kansas, we actually put in a master circuit because it was just easier to do that than to have 25 different areas. And so we kind of helped with that infrastructure just so we could reach more hospitals. And if you look at Montana, when we went into Red Lodge, Montana, we actually had to wait a year to get the connectivity in there, because they actually had to bring the fiber around a mountain. And so there's all sorts of different problems that we've had, and Indian health centers have been really difficult to get that in with just kind of a lot of federal and Indian Health Center red tape. So I think actually from a Texas standpoint, we haven't had a ton of problems. They've been pretty easy to work with, and we've been really excited to have really good connectivity there in Texas. And so one of the CEOs of Preferred Management, actually we were chatting one time, and he is over many hospitals there in Texas, including Van Horn, and he was telling me that he had checked what our connectivity time was from Sioux Falls, South Dakota to Van Horn and back, and it was 50 milliseconds. So when you're telling someone how to do really life or death procedure, it's important that you don't have lag time. But then he also told me that the time it takes for a rattlesnake to bite you is 75 milliseconds. And so it's faster than a rattlesnake bite. And so that was something that I have loved about working with people from Texas, is I learned all sorts of things about snakes, including how long it takes a rattlesnake to bite you.
I love it. So one of the other things that many people are interested in, and I'm not sure that we have a lot of rural practitioners in NAM, but maybe some have found their way to this webinar. How do you pay for this? So Kelly, your process started as part of a big system of care. Alex, you're actually part of a big system of care for a lot of what you do. But when it's provider to provider, if I want to talk to an ID specialist about a COVID patient, how do you pay for that?
Well, if it's intra institution, we absorb that cost, obviously, because it's a team-based approach for the way we approach our care. But if it's a provider to provider across an external party or another hospital system, usually there's some kind of arrangements that has been taking place ahead of time. For instance, what we've done in the past in terms of those specialty type of consults is that we've arranged to have a nephrology or something like that available. And then the provider on the client side, let's just call them that, consult with our nephrologist. We assign billing to them, and then they bill, but they pay us a flat rate. So that's one mechanism in which we've gone around providing that specialty to a peer-to-peer type of consults.
Interesting.
Yeah.
And I would just kind of layer on that. I think, our specialty consults, such as infectious disease, they just bill as they normally would. For many of our other programs, for example, our emergency program, that's a B2B, business to business contract. Because billing is difficult that way. And that may be something that changes after this year, and some of the things that maybe Nora is working on with, how do we work together this way? But we can then assign, depending on how many emergency department visits they have per year, we actually assign then a flat rate. And so they can hit the button as many times as they want during the day, or once a day, whatever they want to do. And so they don't ever have to think about if a patient has insurance, whether or not they would ask for assistance.
Yeah, I mean, that's definitely the subscription or retainer model is one way that's been very effective across multiple B&B organizations. Another one has been like per click, whatever, flat rate per click or per hour. Like we make our specialists available to an organization 4 hours a week, and they choose when they use those 4 hours, et cetera. So there's different ways in which you can kind of massage and play with how payment is rendered.
I think the thing I would add to that, I have a bunch of cliches that people like Dr. Vo, who've heard me speak more than once, are sick of hearing me say, but the heart of every cliche is some truth. And in this case, one of the challenges that we've always had in telemedicine is that fee-for-service medicine is not compatible with telemedicine. Because anytime you are increasing access, if you're dealing with an actuarial mindset of, they did 5 more visits, so the insurer had to pay for 5 more visits, and you're not looking at how that nets out from, we avoided a hospitalization, we avoided an unnecessary ER visit. Fee-for-service medicine has really been the enemy to the growth of telemedicine across the board. In the scenario that Dr. Vo was painting, I get pushback all the time about, well, why would we pay twice? Why would we pay a facility fee to these people over here and a consultative fee to these people over here? It really has been a struggle from sort of an actuarial perspective. So I think 2 things that help with that. Number one, obviously, it's going to be tougher, I think, for a lot of rural providers to transition to value-based care, but most of them are in systems of some kind. So I think that that's a piece of it. I think the other piece of it, and I'm going to give some props to Texas A&M University. We just got our first cost effectiveness data on telemedicine and Medicaid, and it proved what I've always intuitively known. Yes, there are more office visits, but we can prove ER diversion. And that is a really, really, really big deal, because as long as that was speculative, we were always getting some pushback. So now that we have better data, that's a theme I've come back to twice already. We're in a better place as a community to negotiate appropriate reimbursement based on the value that the sort of work that Dr. Vo and Dr. Roan are doing to the system, and not just a little, oh, that was a visit, got to submit a bill. That's a restrictive mentality. It doesn't help these services grow and flourish. I have a strong opinion about this, in case you can't tell.
But now I practiced for 20 years as a solo practitioner, and so I'm one of those people who feels the hair on the back of my neck when you say most of the doctors are in systems. That's probably statistically true, although in small towns there are many of them trying desperately to hang on to their independence. Many of the small hospitals are trying to hang on to their independence, and yet here's one more innovation that looks like it might not occur unless we get these great big systems involved. And great big systems aren't always equal opportunity for their metropolitan versus rural areas. So,
well, if I can tack onto that, that's something that we face, since '94 as we expanded our telemedicine program, across our region for the various patients that live, near UTMB or a little bit away from UTMB. And that's actually the argument that once we go into a community and meet with the providers in those communities, that's the solo practitioners, the family doc, they were really fearful, to be honest with you, about us coming in, big bad UTMB is going to come in and take over their practice. And that's not true at all. We actually, the approach that we took was, we actually will help your patients stay with you because we are augmenting services that you lack. And so essentially, if you are a partner with us, your patients stay in your community. They don't come to Galveston. They don't come to Houston. They stay where they are. They see you as the medical gateway and the medical home for all their needs. And we're your partner for the specialty services. And after, a number of sessions, they actually start to realize, UTMB is a great partner for me to maintain my business because my patients stay with me. They don't go up there or anywhere else. And so it takes a lot of convincing, but definitely an argument that we face at every turn when we went into every new community.
Well, and I think just one more thing on that. I think there's a role for the state in supporting those small providers, Dr. Dickey, and you and I and other venues have sort of talked about that. Whether it's technical assistance, grant writing assistance, whatever it is, preserving that rural safety net should be a priority for the state of Texas. And that's not just a conversation about Medicaid reimbursement rates. That's sort of a conversation about, do we have the right regulatory reimbursement structural policy to wrap around those small providers to let them still be who they are, so they don't feel like their only choice is to join part of a bigger system, which has some advantages, maybe more actuaries, maybe more lawyers. That might not be good. But if we really want to continue kind of the Texas tradition of helping those providers, the state's going to have to make some decisions about how much support we give and what that looks like.
Well, and as you were talking about the broadband activities in the next session, you mentioned business development, economic development. Well, it will be nice if you got enough broadband out that people could work from distance and stay in small towns. But if they can't get healthcare, they're not going to go there. So we do have a couple of questions, and I may be pushing these questions a little bit outside of the telemedicine boundaries. So see if you're comfortable. They're beginning to distribute vaccines, and the first vaccine distribution list in Texas came out. It'll be interesting to know whether the other states are doing something similar. There's challenges. The smallest town on the list for Texas distribution was College Station. So none of those small towns in South Texas or West Texas are getting any vaccine. What are the challenges going to be? And does that mean it's likely that urban livers are more likely to get their vaccine than rural residents are?
Here's what I feel comfortable saying. I was on a call with a West Texas legislator's chief of staff yesterday. There's a couple of things complicating this. Obviously, the issues with the Pfizer vaccine need to be kept cold has caused some concern about getting it out to and keeping it in rural areas. I'm not sure how valid that is, but that has been brought up. The Texas Organization of Rural and Community Hospitals has written a pretty aggressively unhappy letter to the state saying that they don't feel that the plans to do this are taking rural health concerns into account appropriately. This just happened, so I don't know that the state's responded to the letter, but given the situation in West Texas with the COVID deaths, there's definitely a heightened awareness of the need to get the vaccine out to rural areas among those providers. It's just being weighed by the distribution task force against everything else. And I think Torch's pushback is going to make a difference. And I think the legislative delegation from West Texas is all over this. They're very frustrated, but hopefully that frustration is just momentary and logistical and can be worked out. That's all developed kind of over the last 72 hours on some of the calls I've been on. So it's a really great question for folks to be asking. I'm just not sure at this point that the answer is that we know for absolutely sure.
Well, and it's possible, since distribution and the storage, the requirement for maintaining temperature might have been a challenge for rural areas. It's hopeful that the next vaccine is hard on the heels of the Pfizer vaccine, and that perhaps there will be a different kind of distribution. Because that, again, not necessarily the area of expertise of this particular panel, but the second question is, what kind of public health impact might a disparity in vaccine distribution have on efforts of the state? Now, Kelly, you may or may not be comfortable weighing in on this. We watched for a long time the more rural states in the country seem to be relatively I don't want to say immune, but less impacted by the pandemic. And then all of a sudden, boom, North Dakota, South Dakota, the mountain states. So what kind of public health impact and how do we use all of the tools we've been talking about to both fairly distribute the vaccine and then get patients to take the vaccine?
Yeah, I mean, I think it's hard. I think, being here in South Dakota last week, we had the highest death rate in the country, and that's not a place where you want to be. We're also in a point where we had no ICU beds, and really no ICU beds in any of the states near us. And so, from an emergency standpoint, in all of our states, we have spent a lot of our time helping rural areas first of all, manage patients in small hospitals that are typically not taking care of these patients, but also helping to find patients who absolutely needed to move out to someplace because they needed a procedure or something like that, and calling 10, 12, 13 different hospitals before finding a bed and helping manage. I think, it's really going to be important for us to model behavior of taking the vaccine and teaching and educating about safety and what is coming out from the FDA, which is going to be coming out here in the next couple of days. And we expect that we'll start vaccinating up here in South Dakota next week with the Pfizer vaccine. And we have actually talked to our rural counterparts about the fact that probably those first vaccinations are going to be going to our more urban areas, but just to the front line, so ER, ICU, COVID units. But then we will be going to our rural areas and everybody. So the clinic nurse in a rural area will be getting the vaccine likely before the clinic nurse in an urban area, because we know in rural areas, most of those nurses are covering everything. And so that's kind of how we have helped a little bit in trying to make it maybe a little bit more equitable. So that's where we've kind of started in that regard.
And this is a place, again, that it's possible that those entities that are part of a system could end up moving to the front of the line because the system gets a number of doses and chooses to distribute it outside of their solely metropolitan areas. Let me change topics a little bit, though, and get back to our telemedicine. Dr. Mehta says, how are patients educated? We haven't spent a lot of time talking about this, but there's certainly an increase, not only in the provider kinds of consultations, but in provider to patient. Dr. Vo talked about thousands of visits, tens of thousands of visits increase. How do patients know how to use telemedicine? Now, I've been practicing for 40 years and I've been doing telephone calls. That's a little different than trying to interface with your doctor through a mixed media kind of event. So how do you educate a patient both when is the proper time to use telemedicine and how to get the most out of it?
Well, from our perspective, there was a couple of revolutions in entertainment that actually has helped with educating the consumer on how to use telemedicine. I mean, the advent of FaceTime, the advent of Zoom, this platform right here, video conferencing, it actually, we thought the more elderly patients were going to have a difficult time utilizing telemedicine because they'd have to navigate all the technology pieces, but it turns out that was not founded at all. They were really well versed because a lot of these patients were already FaceTiming with their grandkids, et cetera. And so it was not that hard for them to do. And some of the outreach, definitely you have to do outreach. A lot of one pagers that explain how to use telemedicine, that it's secure and safe in the platform we use. And so educating on those. And nowadays, just like this Zoom call, the appointment is based on a link. And so you click the link, it goes into our EMR system, and we're able to pull them up in a secure way. And so it's not like they have to enter in and launch a number of applications and navigate through those things. So it's become much more simplistic to utilize telemedicine. It's just, we just have to do a little bit more upfront in terms of educating them with either paper cheat sheets and then our access center, which is a nurse triage line, can walk through how folks can actually utilize telemedicine for their appointments. So those are some of the things we actually implemented this year, which turned out to be fine. So Dr. Roan, do you have any comments on that? How you guys educate patients using telemedicine?
Yeah, I think ours is very similar to yours, Dr. Vo. I think we just work with our vendors as well. I think, they're really receptive to making sure that it's easy on both sides. And I think you really need to look at how that affects your patients, but I think physicians too. Now, just like Dr. Vo was saying, all of those physicians and providers in one weekend went live doing telemedicine, and many of them had never done telemedicine before. So now we're going back and kind of helping to do some training on how to do telemedicine with our providers and looking at processes to make it easier and work in their workflow in the clinics, which has been really helpful. And some of them have said they will continue to adopt this long after COVID because it actually works in their workflow very well. And from a patient standpoint, we had similar, we, talk people sometimes through on the phone to get the app working at the beginning, but from pediatrics to geriatric care, they actually really enjoy it.
So I have to say, two of my favorite little tidbits from the pandemic. First of all, my own personal doctors all know what I do for a living. So as I was doing telemedicine visits in the early part of the pandemic in particular, the first 5 minutes of each visit was them saying, look at me, Nora, I'm doing my very first telemedicine consult and I'm doing it with you. And it was adorable and endearing. And every single one of them did it differently, had a different platform with a different onboarding and a different process. And what we're seeing in industry is that that is all getting streamlined, because we have a habit in healthcare of dropping new technology on top of old workflow and going, okay, that's good. And that's actually, I bet Dr. Rohn can tell some stories. That's not good. You have to put it in a workflow that makes some sense, not just kind of replicating your in-person workflow. So just from March to November, I've seen that improve significantly. And then the other thing, I want to hook on to what Dr. Bo said about the EMR. Most major EMR vendors now have a telemedicine partnership of some sort that primarily supports physicians and primary care and that sort of thing. And I have his permission to tell this story. My 86-year-old father-in-law, who is a Texas A&M graduate, thinks his patient portal for his primary care doctor is the greatest thing in the history of the world. He can look things up, he can send a note, he can look back at his visits, and he would love it if he could chat with his doctor through the patient portal, because that's a thing he already knows and he's comfortable with. So if my Aggie father-in-law can do it, gives me some hope for the rest of us. And he knows that I make that joke because he gave me permission to use him as an example for when people say, well, what about, obviously there are going to be elderly folks that don't have that kind of access. But every grandparent wants to see their grandchildren. Dr. Lowe hit on that. You know, everybody's FaceTiming with their kids or Facebook portaling. 10 years ago, we would have had a much steeper incline to get over than I think we do now with some of the patient-facing adaptation.
I think it's actually 5 years ago we had much better incline. I think you're right. You hit on a really important point. Technology now has allowed our providers, our patients rather, to be connected to our providers in multiple ways versus, you know, going to the clinic. Now you can do a video conference, but like you said, Nora, a chat or an email feed, you know, that may not be synchronous right away, but you know the provider can respond with an answer within 24 hours. So that's multiple mechanisms in which a patient could communicate with their providers. What was important for us and for some of our providers, one was the workflow. How do you don't want them to do something that they're not comfortable with, so that they don't feel like they can diagnose appropriately or treat them appropriately. But so workflow was really important for us in terms of, you know, whatever we did, it had to replicate some of the workflow that our providers engage in. Another thing that was really important for us was that you had to be able, whatever technology you use, you have to be able to replicate to some extent the provider-patient relationship. And that was really, really important in order for providers to feel comfortable doing telemedicine and for our patients to be engaged in telemedicine, because that relationship is very key to actually good treatment, continuity of care, all those things. And so, you know, you can have a really great technology platform, but if it doesn't facilitate that relationship, no one's going to use it. But so basically, you know, my 2 cents on that aspect.
So with everybody so engaged and loving the variety of access, are we going to topple the real estate business? We're just going to close all our offices and all of our interactions now going to be by telemedicine?
No, I think there's always going to be, you know, we're always going to have face-to-face visits, and we're always going to have someone to do the procedure. You know, maybe we're going to be able to do some of that from afar, but I think there'll always be that hands-on piece. I still do hands-on medicine, and I would miss it if I didn't get to do that piece. And so I think that's always going to be there. But I think, you know, when we first started doing laparoscopic surgeries, people probably thought that open was still going to be something that we did pretty often, and it's not very often that we do open, say, cholecystectomy. So but it's still an option. So I think, you know, as technology changes, we'll find new and different avenues, but telemedicine is really just a tool to do medicine. It's not a different kind of medicine.
Right. It's not a discipline, a separate discipline. You're absolutely right on that. And with any tool, there are limitations to it. So there's always going to be the need for in-person visits. So, I mean, but I think the virtual care is going to increase to some extent. So people start to realize that, hey, I can actually do that and accomplish the same goal using virtual platforms versus in person. But at some point, the patient's going to need to come in and see me or my team in order to get the appropriate care. So.
There have been a couple of national studies, one from Chilmark and one that CMS has been quoting, the Centers for Medicare and Medicaid Services. They're estimating that 1 in 5 future visits will be virtual. It'll be higher in spaces like behavioral health. It'll be lower, I think, in some of the other specialties. But anyone who tells you we're moving to a completely virtual world, period, the end, sell all your real estate and go buy Zoom stock, is probably actually trying to sell you something, and you probably shouldn't buy it. The practices of the future are really going to need to be hybrid practices to accommodate their patients that are immunocompromised, that sort of thing. But you're still going to have to lay hands on patients. There's not going to be any getting rid of that for an awful lot of things in order to meet the standard of care, because telemedicine doesn't alter the standard of care, and it shouldn't. We should still be practicing good medicine. So I think that 1 in 5 number seems to me to be pretty reasonable, maybe a little higher, like I said, for behavioral health. Don't sell your real estate.
But do buy Zoom stocks. It's pretty good right now.
Or Cisco or any of the publicly tradeds that's in this space is probably, I should have invested in that and the companies that make the masks. Those would have been good early on investments.
Well, and everybody keeps thinking we're going to get rid of them with the vaccine here, but I'm hearing another 6 months before we're far enough down the path from a public health perspective. So it's not too late, Nora. Go ahead and buy some stock. There you go. I want to thank our presenters coming from 3 very different perspectives in terms of telehealth, but all indicating the important shift that occurred as a result of the pandemic and the possibilities for this to really continue almost a tsunami-like effect in terms of access to care in some of the areas that have the most challenges to local health care. I think we still have a lot of advocacy work to do. And so any of you who are listening that are involved in advocacy, remember, broadband policies that make it possible to use telemedicine in ways that weren't allowable until the regulatory changes. And keep in mind that this is an area of medicine that's going to continue changing very rapidly, both rural and urban. So Terrence, with second thanks to our speakers, let me turn it back to you.
Thank you, Dr. Dickey, and thanks for organizing and hosting such an informative session. And thanks to all of our speakers for your time today. We talked a little bit about connectivity and want to just acknowledge and apologize for a little bit of a connectivity issue with Dr. Dickey's video, but most importantly, we still had your audio. So we're really glad that we could have all of you here today. We will have the video of this session posted on our website tomorrow, as well as the slide presentation. You'll also receive a link to that in a follow-up email that we'll be sending out tomorrow. You can also check out past sessions that we've had in this series on COVID-19 on our website, TAMEST.org. And you'll have a survey pop up when you're done in the webinar today. And we'd love your feedback and any ideas you might have for future sessions that TAMEST can convene on. We're going to take a little bit of a break over the holidays, and then we're going to come back on January 13th, Wednesday, for a very special online award ceremony for the Edith and Peter O'Donnell Awards. This is a really stellar program that TAMEST is involved in that recognizes rising star researchers in the state of Texas. And we'll be announcing them and recognizing them on January 13th online. You'll receive an email invitation to that in the follow-up email tomorrow. So with that, I want to thank again our moderator and our speakers and all of you for joining us today. Please have a safe and happy holidays, and that will conclude our session for today. Thank you.